Peach Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing child and young person education to primary care clinicians. Today I'm meeting Majumdar, consultant paediatric neurologist at Bristol Royal Hospital for Children, to talk about chronic headaches in children. Good morning, Arnie.
Hello.
Thanks so much for meeting me today.
Thank you very much for inviting me.
And thanks for coming to speak to us today on chronic headaches in children. Could you give us a bit of background? How do you define chronic headaches in children and how common are they?
Yes, of course. So headaches are common. Everybody gets a headache. Children are no different, and children get headaches, but the headaches in children can be quite tricky at times to work out exactly what they have, because children grow and change, and their ability to communicate their symptoms also changes with them. We know that chronic headaches are very common in especially teenagers, and they can be a burden for these children and their families, leading to a lot of missed school and missing out on education. So I think it's quite important to try and identify these headaches, to diagnose it so it can be appropriately treated, allowing them to engage in all the things that children and young adults do, especially education.
And is there a cut-off of what we call chronic headaches?
The definition that is usually used is the International Headache Society classification. For those who are interested, you can find that on the internet, but it's quite detailed and it's mainly for research purposes. But at a very simple level, chronic headaches are headaches which affect you for half the month, 15 days in a month. That's really the only criteria that you need. Those who talk about whether it's going on for certain hours or not, but I think the mainstay of the classification is headaches. 15 days in a month, then they're called chronic headaches.
Brilliant, thank you. If we now use a case to base our questions around, Jenny is 15 and has been getting headaches for more than a year. She'd been a fit and active child who had a bad cold one winter, and then over a period of 2 weeks her headache started. She used to get the occasional migraine, but this headache was different. She said that this headache's there all the time, from when I wake up to when I go to bed. Some days it's not too bad, other days it's unbearable. Sometimes I get shock-like pain on the top of my usual headaches, and they're really horrible. There is no vomiting or visual disturbance. Are there any features in this history that you recognise as typical for chronic headaches in children and young people?
Often in chronic headaches, there seems to be a sentinel event, some trigger which seems to set them off. That could be as innocuous as just a viral illness, or sometimes it could be a slight bang to the head. It could be some injury that somebody sustained, but it's mainly a non-specific viral illness of some sort. And then what these children and young adults often say is that the headaches are a little bit different from what I normally used to get. Now, they may not classify it as a migraine or a tension, but they say, normally when I get a headache, it's infrequent, but this just came on after the illness and has just been really annoying. It's there all the time. But they also describe a very typical type of headache, and if you ask children, they will tell you about it. If you score the headaches with 0 as no pain and 10 as the worst pain you've had in your life, the children will often say that my pain is somewhere between 4 and 7, and it's there all the time in the background. But occasionally I will get these spikes of intense pain going up to about 9 or 10, and then that'll be for a few seconds, and then it'll settle down, and then come back again and settle down. And this graph of a background level of 4 to 7 and then spiking to 9 is very well described in the literature. And most kids with chronic daily headaches, you tend to find that if you ask them.
Interesting. Thank you. So how would you approach Jenny?
Approaching the history is something that is fundamental in what we do. And with headaches, it is particularly relevant because your diagnosis is ultimately based on your history. Especially in general practice, it is all to do with the history because you are highly unlikely to find anything on examination. So your diagnosis is 99% based on your history. The trick is, how do you fit in a sufficiently detailed history in the limited amount of time a general practitioner has? It means that one has to focus on certain aspects. First of all, immediately when you see a child with headaches, you want to try and rule out if there are any red flag signs, because those are the things that would cause you to maybe send the child down to the emergency department, because ultimately everybody's always worried about, have they got a brain tumor causing these headaches, which is usually highly unlikely, but the way to exclude that is by ruling out some of those red flag signs. The second thing is, it is worth spending maybe a few minutes getting the child to describe the headache, exactly the quality of the headache, where it is, the intensity, and also seeing if there is any aura associated with it, usually before the headache starts. Those are things that I would use to try and make up my mind whether the headache is more migrainous or tensional in nature. This does depend very much on the age of the child. The older they get, especially when they become teenagers, what's going on outside their home life, especially what's going on at school, how much stress they're under, and whether they're using illicit substances, whether they're actually overusing medication, because teenagers will quite happily pop a few pills to get rid of their annoying headache. These are the things to look out for. We know that school is one of the most stressful things that teenagers do. We also know that during the pandemic and the increased use of social media, kids having mobile phones all the time, whether it's affecting their sleep, whether they're not sleeping and their sleep cycle is disrupted because they're constantly on social media, all these things have an effect. One of the potent drivers of chronic headache is sleep and stress. Of course, diet and exercise are very important as well, but if you're not sleeping well and you're under stress, until those two things are addressed, chronic headaches often do not tend to get better. I look at them as two sides of the same coin, almost. So sometimes in my practice, when I'm treating the headaches, I almost always try and look at some of these other factors like stress and sleep, and sometimes try and address them in order to get the headaches better. And then the other thing which often gets forgotten about is the family history, because most kids with headaches will have a family history, especially those with migraines with aura. So that is what I would focus on, and it will hopefully reveal most of the answers. Carrying on, of course, after the history taking, you would want to examine this child. And again, how do you fit the essential components of the examination within the limited time that you have? Well, I would suggest their height, their weight, their head circumference, their blood pressure, and then to look at the fundi to see if there's any evidence of papilledema. Eye movements, balance, coordination are the other features that I would look at. Now, of course, it is never easy to look at the fundi in a child, especially small children. Nobody's going to criticize you if you're not able to do that in your GP practice, because a lot of children are often sent to the emergency department of the eye hospital specifically for them to have the back of their eyes looked at. So if you are able to do that, that's fantastic, because if you have a normal looking fundi, it excludes a lot of very sinister causes for headache. And then the other things that I mentioned, which is coordination and balance. All you have to do is get the child to walk up and down your consultation room, get them to turn around and see if they are a little bit wobbly or lose their balance slightly. Sometimes when you're talking to children, you might see the odd nystagmus. That's quite unusual to find, but these are simple things that you can do in your clinic room.
You mentioned red flags. What red flags should a primary care clinician be looking for?
These children, when they come in, if they are really quite wobbly on their feet, for example, they are grossly ataxic, that would definitely be a red flag. If they have evidence of papilledema or their vision has changed, that might be the only thing you notice, because it might not be easy to see the back of their eye. That would be a red flag sign. They are often vomiting because migraine is associated with nausea and vomiting. But if it's vomiting with no relief of the headache, then that's a red flag sign. And of course, there are signs of infection, signs of sepsis, and signs of meningitis or meningism with neck stiffness and photophobia. These are probably the standout things that you can see at the end of your clinic room.
Thank you. Jenny's parents, as parents often are worried about a potential brain tumour. As well as looking for these red flags, are there any particular clinical decision-making tools, such as HeadSmart, that you use?
Yes, there are a number of decision-making tools. HeadSmart is the one that it's actually been in the news recently, I believe. Dr. O'Malley, one of the emergency department consultants at the Bristol Children's Hospital, has been driving this and has developed an app for it, which I would recommend. There are a number of other charities which have tried very hard to highlight this issue and raise awareness in the community. Of course, all these things are fantastic, but ultimately, when parents come in with this anxiety, one of the things that a general practitioner can do, and they can do that if the history fits a certain headache phenotype, and if the examination is normal, is the GP can actually reassure. And reassure to the point saying, this is highly unlikely to be a brain tumor. You don't need an MRI scan, a CT scan for. I really do think that is an important message to give parents. Of course, parents sometimes, especially in the context of chronic headaches, with the headaches that are rumbling along for days and days, will often want a scan. But if you have a normal examination and your history fits one of these headache phenotypes, almost always you can reassure these families. HeadSmart helps the parents, hopefully to relieve their anxiety. HeadSmart helps the practitioner to make sure that they have looked and considered various things. And it also has specific sections where it illustrates what the red flag signs are in case you can't remember on the spot. And it tells you when to refer kids in for specialist opinion or to the emergency department. So as an aid memoir, it's a fantastic resource.
So it's a great resource for families as well as clinicians, is it then, in your experience?
Absolutely, yeah. I often not only use HeadSmart, but often use the Migraine Trust website. So it's migrainetrust.org, because those websites, really the focus is on the patient and their families. And it has a lot of helpful suggestions that we as doctors often just don't get around to talking to the parents about. And actually, if you refer them onto these websites, then they, in their own time, are able to look at these things which are probably going to be much more relevant for them, such as how to reintegrate back into school, how to ensure that you continue to have a good, healthy lifestyle, sleep well, do proper exercise.
So Jenny is a poor sleeper. She goes to bed late and often wakes up very late. She has a BMI of 30, which is 95th centile for age, a normal neurological exam with no papilledema and none of the red flags mentioned. Would Jenny warrant further investigation?
That's an interesting question, because those children whose sleep is affected, one then has to start considering, why is the sleep affected? Is it just because of the ordinary stresses of the day? Or is there some pathological process going on with their sleep to then give them headaches in the morning? So the classic one is obstructive sleep apnea, and of course it's often associated with snoring. The other issue is being overweight. That does predispose you to obstructive sleep apnea and sleep disordered breathing at night. And of course, that can then impact on the headaches that you're getting during the day. The other thing that is unusual, but we do see, is this association with being overweight and idiopathic intracranial hypertension, IIH. Now, the thing about IIH is we think the systemic venous return to the brain is reduced because of obesity. And that can lead to the situation where you have raised intracranial pressure, but that almost always gives you some changes at the back of your eye, papilledema. So in this girl, I'm probably much more concerned about the possibility of obstructive sleep apnea rather than idiopathic intracranial hypertension. But both those thoughts will probably have gone through my head. When it starts becoming complex like this, where it's probably more than your average tensional or migrainous headache, this is a pretty typical referral. And if you are really worried about something, this is where the emergency department may be able to help out.
So I guess that's a good example of you using sleep and stress as other sides of the coin from chronic daily headaches. If we take those features away now, so we imagine that Jenny was sleeping well and that she was a normal healthy weight, and therefore we're looking to manage in primary care, how would you want the primary care clinicians to manage her?
At this point, one needs to go back to what I call the headache phenotype. whether this is a primary headache or a secondary headache. In other words, is this a migrainous type headache or is this a tensional type headache? Now, if it is a migrainous type headache, there are some simple anti-migraine medication that one can use. And the way we like to think about this is, can you prevent the migraine from happening? And that's where preventer drugs come in. Or can you use acute treatment drugs for migraine? Then it's a matter of trial and error, giving it time to see what the effects are, bringing patients back to your clinic. Because unless you do that, you do not know whether these drugs and things that you're trying are going to work. The management of headaches is a bit labor intensive because you cannot just give them one medication and say, that's fine, you'll be okay, go away, I don't need to see you again, because that will not work. They will continue to have problems and they will come back. It pays in the long run to follow them up. The tensional side of things can be sometimes a bit more challenging because the acute treatments for tension headaches really are very limited, mainly paracetamol and brufen. We really do not like codeine-based medication because they tend to give you lots of side effects like constipation and often give you medication overuse headache, which is a problem in itself. So with tension headaches, it pays to go back to finding out what else is going on with this child or with this school and with the family. I saw a patient in my clinic yesterday with tensional headache, and the headache was clearly identified as being related to the stresses at school. Because the question I asked is, how are weekends? She said, weekends are great. How are holidays? Fantastic, and never get a headache. So that tells you, no matter what pill you give this child, unless the school situation is sorted, they are not going to get better. And that's what I would suggest people do about tensional headaches.
So target those lifestyle features. Think about sleep, think about school, think about stresses.
Absolutely.
With Jenny, there aren't obvious migrainous features, so would that be the bulk of the management with her, looking at lifestyle, sleep and stress?
A lot of the management that one can do in primary care is addressing those lifestyle things. It goes a long way to educate both the young person and the family about what these headaches are. One aspect of education, and again, all this information is available through the Migraine Trust website, for example. One of the aspects of education, which I think is important, is self-reliance and understanding your own symptoms. There are some headache diaries and there are apps which help you monitor your headache. And nowadays, everybody seems to have these Fitbit watches which tell you how well you've slept in the night or how badly you've slept. If the young person knows there are certain triggers which sets off the headache, certain things or certain times of the day they're going to get a headache, why wait for that headache to be established? Can they not take something to prevent it? It sometimes takes a while for parents and the young people to understand that. But that simple education and that simple recognition and self-help can go a long way.
Do we classify migraines in children the same way that we would in adults? You've already talked a bit about how the pattern can be different with things like cyclical vomiting, but when we have a child in front of us, can we use the adult criteria or are there any differences there?
The adult criteria are applicable, but one needs to be careful about applying those to children probably less than 7, because children less than 7 tend to present in much more nebulous ways. Cyclical vomiting is a classic example. They may not actually talk about pain. They may not talk about an aura. The classification utilized by the adult certainly is applicable to teenagers.
Am I right in thinking migraines can be a lot shorter in children?
Yeah, that's correct. There's a vast variation to the duration of migraine. Some can be short, and headaches in children can be very, very short. They are called idiopathic stabbing headaches or ice pick headaches, nasty, often behind the eye, but fortunately they last for a very short amount of time. Bespoke and specialist headaches like that probably warrant a referral to your local friendly general pediatrician.
Thank you. Can you talk to us about the management of migraines in children and young people?
So, prevention of migraines, first of all, can you avoid some of those triggers? In very small children, the triggers may not be obvious, but in older children and teenagers, it becomes very clear what the triggers often are. And as I've mentioned before, it's stress, it's not eating correctly, it's lack of sleep. These are the biggest stressors and triggers for headache. Everybody always knows, and you learn in medical school, about cheese and red wine. I'm not too sure many teenagers like cheese and red wine. They perhaps like Alco Pops.
Yes.
That's a different matter. But on a serious note, teenagers may be abusing alcohol. And of course, alcohol abuse chronically will be a potent trigger for headaches. There's the possibility that there might be other drugs that they are taking, which they will not mention to you with their parents in front of them. But it needs to be considered because they can also completely disrupt the sleep cycle and provoke headaches.
Do you find that hormone changes with menarche is a common trigger? Or is that not something you see so much with children and young people?
It's a very interesting question because I am always a little bit concerned at what puberty will bring. What I do know is the nature of the headache changes. So if you take the lifespan of a child having inherited migraine from someone in their family, they may, under the age of 5, have just a cyclical vomiting type picture. Parents can often predict exactly when they're going to vomit. Then that evolves into this non-specific headache associated with maybe some autonomic changes, color changes, vomiting. Sometimes that then changes to having weakness around the face or weakness in the arms or legs, a familial hemiplegic migraine component. And then after puberty, sometimes the headaches just get better and sometimes they get a bit worse. I'm not really too sure I know whether there's any rhyme or reason to why that happens. And this is why I'm always a little bit concerned around the time of puberty. I tend to follow kids up till they are well after puberty to ensure that I've got some handle on what's going on with them before I either hand them back to the general practitioner or to the adult services.
Great, thank you. And could you talk to us a bit about the prophylactic medication options we have? Do you have a standard go-to or how do we decide between them?
There are a number of first-line preventative agents that we often use. Pizotifen, propranolol at a low dose. Females are often said to like cyproheptadine. I don't have that much of an experience of using that. These are often the starter prophylactic medication. Then as things develop and as the headache phenotype becomes clearer, if the chronic pain aspect is not being well controlled, one can try drugs such as gabapentin or amitriptyline. Amitriptyline for chronic pain and chronic sleep problems is fantastic. Sometimes in children who are overweight and need help with losing their weight, they can try drugs like low-dose topiramate, which often helps with weight loss because it does suppress the appetite. And ultimately, if there is a specific problem like idiopathic intracranial hypertension or obstructive sleep apnea because of obesity, then regardless what preventers you're going to use, these kids are going to need some sort of specialist pediatric input.
It's often difficult in children and young people to determine the phenotype of the headache because there's often a lot of overlap between the migrainous features and the tension type headache features. Is it important for us to be able to distinguish the difference? Or do you have any tips? You've already talked a bit about amitriptyline and gabapentin as generic treatments for chronic headaches in children.
Trying to disentangle the overlap features can be helpful because if, for example, you want to treat the migraine aspect of the headache acutely using an acute anti-migraine medication such as a triptan, that can be helpful, but it's useful to have classified that headache as a migraine component. But the reality is, and especially in younger children, these headaches are all mixed up. It's quite difficult to disentangle them, and sometimes you just do not get a very specific history. Kids will often come in and say, "It hurts all over my head."
Thank you. You mentioned that following up these children saves time in the long run. What's your ballpark for when we should be following them up in primary care?
My own personal way of following these kids up is that I do tend to follow them up initially 3 months, 4 months, and then 6 monthly, and then once a year. By the time they're getting to once a year and maybe just wanting a telephone follow-up, they're probably appropriate for discharge. The other reason why I do like to follow them up, you actually know from the end of your clinic room if the treatments are working. They look brighter, gone are those dark clothes and dark sunglasses. Often the t-shirt that they wear just tells you their own story. And inevitably they want to be a doctor or a psychologist.
Because you fix them.
Well, perhaps. I've seen this enough times now over a number of years to know when my headache treatment is working.
Interesting. And is there a role for magnesium or other over-the-counter supplements when it comes to migraines in children and young people? It's a question I'm often asked by families.
Yes and no. My take on alternative medication is, as you search through the internet, you will find a lot of things. Magnesium is one of those things. Riboflavin is another one. Chinese herbal medicine is often talked about. It's difficult for me to say whether one is scientifically proven to work better than our standard medications available in the NHS. But for the child and the family, sometimes if things are desperate, they will be looking at alternative treatments. And if magnesium works for your child, or riboflavin works for your child, or acupuncture, or Chinese medicine, or hypnosis, you're unlikely to do any harm. So I'm actually very relaxed about alternative therapies. And I tell parents, do not be afraid to explore alternative therapies if you want to.
So would I be right in gauging from you that there's very limited evidence that it works, so you wouldn't push parents towards that, but equally that it's unlikely to do harm? So if alternative therapies are something families want to explore, you'd support them with that?
That's exactly correct, yes. I try my best to work with families.
There's obviously a huge range of differentials that can cause chronic headaches in children and young people, including obstructive sleep apnea and idiopathic intracranial hypertension that we've already talked about. Are there any other particular differentials that you would want to highlight?
The differential for headaches is enormous. There are many, many sinister causes of headaches. Fortunately, we very rarely see. But I think at a very basic level, you want to ensure that you're not missing a tumor. That is going to be the number one concern for most families. You also, through your history taking and your hopefully normal examination, want to be able to reassure the families. Now, if there is any other cause, whether it's sinister or a rare, unusual cause, you will probably find that none of the treatments or strategies that you are trying are getting better. And it's at that point it is definitely worth considering a referral to your general paediatric friends.
Thank you, that's really helpful. And that leads us nicely on to when to refer. You talked about secondary causes such as obstructive sleep apnea or idiopathic intracranial hypertension. You've mentioned the child that's just not getting better and the red flags for brain tumours. Are there any other indications when we ought to be thinking about referring to secondary care?
There are lots of other potential comorbidities, which I really think to address them takes time and effort, which I do not think a general practitioner is going to have. And that's really where these referrals need to be made.
Perfect, thank you. Do you have any key take-home messages for primary care clinicians?
Yes, the key take-home message is talk to the kids. They will tell you what their headaches are like. And on the basis of that, you can probably identify what their headache phenotype is. The vast majority of headache phenotypes that you will get will be either tensional or migrainous in nature. Ask about the family history. And if you have the ability to do a very basic clinical examination and it's normal, then that should be reassuring you that you're not missing a brain tumor. Of course, we are available through the emergency department, through the hospital. If you're ever concerned, you can always ring up for advice. And if you are really concerned, you can always send the children in. Most of us will be able to see these kids at pretty short notice because we have triage algorithms to ensure we never miss an urgent case that needs reviewing.
I think for me, some of the key take-home messages are that extra importance of the family history in children and young people with chronic headaches, because it is so hard to depict the exact phenotype of the headache. Use of medications such as amitriptyline and gabapentin for prophylaxis in chronic daily headaches. That's something I would be a bit cautious about doing in children and young people, so it's good to know that that is common practice. And from discussion around the recording of this podcast, that we should be cautious about diagnosing migraines in children under the age of 5, and that actually under 5 they would warrant scanning and referring. We've already mentioned HeadSmart and the Migraine Trust website. Are there any other key resources that you'd like to highlight for families or primary care clinicians?
Through Bristol Children's Hospital, there are a number of guidelines available. There is a pediatric headache in primary care guideline. I urge you to have a look at those. I have been involved in a British Paediatric Neurology Association initiative known as CHAT, C-H-A-T, that's Children's Headache Training, aimed at general pediatricians, but it is a virtual 2-day course where the basics of children's headache are taught. I would highly recommend that course because once you do that course, you will be very confident about managing children's headaches.
Brilliant. Thank you so much. Thank you for joining us today.
Thank you very much. It's been a pleasure.
The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen, and interviewees are not liable for any clinical decisions made as a result of this podcast.